National Health Service is a nationwide publicly funded health service that treats millions of people every week within England, Scotland and Northern Ireland. The system employs approximately 146,000 doctors, 370,000 qualified nursing staff and 37,000 managers and growing. In fact, since 2002, the number of clinical staff has risen by 20%, with medical schools seeing a rise in student intake by 59%. How do you know if the decision to become a member of the medical staff is the right choice for you? There are 60 different specialities that a young doctor can choose to focus on. From surgery to oncology to becoming a local community GP, young doctors find their way to a special area interest based on their own experiences, personalities and motivations. TSU professionals spoke to doctors at various points of their career to learn what it takes. Dr. Sang is a registrar and senior doctor at Chase Farm Hospital. Dr. Akinola is one of 4 GP partners at the centre in Kennington. Dr. Ashton is a junior doctor, also known as F2, currently working with John Ratcliffe Hospital in Oxford. Christine is a third-year medical student studying at King's College London. She has completed 3 years and has just finished a BSc. It's a long road to reach a career in medicine. The training starts in undergraduate studies, where students are introduced to medicine.
I think I've kind of always known I wanted to do it throughout GCSEs and high school, and then I applied in my first year of sixth form. Your first 2 years are primarily preclinical, so you're getting lectured on a daily basis, and you have a few hospital visits, so perhaps about 3 or 4 a year, and 3 or 4 GP visits, and that's as much as you would go into a hospital or the GP clinic. So I've only done the preclinical years of medicine, so that would usually involve mostly 9 to 5s every day of lectures. And we'll have a few tutorials where we'll kind of have to answer questions and go through things, and workshops and discuss particular topics and things. But yeah, it's mainly a lecture-based 5 days a week, really.
So I decided when I was about in year 9, I think, and then I tailored my GCSEs and A-levels to that. So I did biology, chemistry, physics and French at A-level. And a lot of people decide to do maths instead of physics, which is fine, but physics teaches you as much maths as you will need as a doctor, and I found it a little bit more interesting, so those were useful. And then French just as something else to do and just a general life skill. I think Oxford does do a good job of preparing you for being a doctor, but it's a career where you really can't be fully prepared for it until you actually go in and do it, and you're the one who has to take responsibility for your actions, and you have to know exactly what to do in any situation and know when to ask for help. So I know a lot of people who studied the sciences at university and then decided to go into medicine after that. It's often because they did a science degree but then felt that they didn't want to go and work in a lab doing research. So medicine's a good option then, because you've learned a lot of basic skills that are useful when you become a medical student. The ability to work hard, to read papers, to analyse information and synthesise it into something. So people did biology and chemistry degrees and then go to postgraduate medicine, which tends to be harder than undergraduate medicine just because it's the same content is put into a shorter space of time, but also by the time you reach that stage you're a much more efficient worker and you know what you're doing. So I think they had a good time as well, and they make better doctors at the end of it actually, because they've got that little bit more maturity and experience. So as a medical student in most universities, you'll do a few years of preclinical medicine, either 2 or 3 years, which is basically the science behind medicine and learning how to work and that sort of thing without much clinical experience. Then they spend about 3 years actually in hospitals doing the jobs of a junior doctor and learning how to do that, learning about diseases and how they manifest.
Coming off of a 13-hour night shift, Dr. Sang talks about the challenges and successes of his career in respiratory medicine.
I was very lucky. I did my training in the South Thames Deanery and they were very organised. I think it's very scary as a junior doctor to be exposed to different things so quickly, because it's the amount of responsibility you have can be quite daunting. But I got exposed to lots of acute medicine and acute surgical problems as well, and I did 6 months in accident and emergency, and I think that helped immensely. Although it was terrifying at the time, I really enjoyed it. I'm currently a respiratory registrar. I did a pharmacology degree first at King's College London, and then progressed through doing a medical degree at again King's College London prior to training as a junior doctor. I chose respiratory medicine because I like the variation in the job. It has different aspects. I mean, you're managing acutely unwell patients, for example, people with pneumonias who are very unwell very quickly, to seeing people in clinic where they've got chronic conditions where you can manage them over weeks and months. So from the top down, there'll be a consultant. There'll usually be one, maybe two registrars that work with the consultant, and then we'll have a team of SHOs that may be a foundation year 2 doctor, maybe a core medical trainee, and then we'll have the health officers, the foundation year 1 doctors who've just graduated from medical school.
As a local GP, Dr. Akinola serves as a first point of call for patients in her community for a variety of ailments.
We're called the gatekeepers of the NHS, so we're usually the first point of call for patients for everything and anything. My background is atypical. I did my A-levels here in England, in Northampton, then went to Nigeria because my dad got a job and did medical school there. I did my house jobs and then came back. Then I started a family. I initially worked as a healthcare assistant and did some cardiography, and then finally did my PLAB and got house jobs in Swindon, and then did my GP rotation in the Oxford region and my training, and then became a GP in Oxford. I used to work as what they call a clinical assistant in psychiatry, and clinical assistants are usually non-specialised doctors like GP with an interest in whatever area. In this case, mine was psychiatry. I'll see patients from 8:30 till about 11 o'clock. After that, have a 15-20 minute slots for telephone consultations, and then I'll see patient again till about 12:30, 12:40. I have to deal with prescriptions. It's done electronically, so I just at the click of a button, and then it's sent to the pharmacist. The patient are able to collect it. Obviously, we take some blood with me previously when I've taken the blood test. So again, from the computer, it's sent down the line from the hospital to us. So I deal with that. As I'm consulting, there might be people asking for prescriptions, urgent result coming through. So after I finish, after 5:36, after that, then I have to deal with results and maybe phone calls. And usually I don't leave here till about 7:38, so it's a real 12-hour day.
In terms of medical school, obviously there's hours and hours of studying because that's all you do. And then you graduate post F2. I applied for core medical training because I wanted to do medicine, general medicine in general, and so you applied to core medical training. And then that takes you to 2 years, and you rotate through all the different medical specialties, going from cardiology to respiratory medicine to rheumatology and general medicine, to just name a few. And it's usually very well structured, and I was very lucky in the sense that I got lots of very good exposure to different things.
After graduation, medical students enter into a foundation programme known as F1 and F2 levels. A 2-year course of training forming a bridge between undergraduate studies and their ultimate specialisation training.
My personal statement was primarily based around my work experience, which is why I think doing as much work experience as possible is great, because then you have more to write about in your personal statement and more to focus on in your interview. But yeah, I think getting your personal statement done as early as you can, and just like being really organised with your time, is very important in the application process, because there's so much to consider when you're applying. it's not just your personal statement, getting your work experience done, keeping on top of your studies, and then UK CATs and things like that for entry exams for the universities now as well. So it's not just limited to working in a hospital or a GP environment, because those are very difficult to find. I think volunteering in a hospice, like I volunteered in St Luke's Hospice, and I think that's really good, and elderly home, that's a really great place to learn about medicine, so you do have other options.
So you need to be prepared to work hard, both whilst you're in medical school and then when you become a doctor. Don't need to be doing anything clinically at all, just soaking in the atmosphere, seeing what things are like. But it doesn't need to be in a hospital. I spent some time in a GP surgery working as a receptionist, and I didn't do anything clinically based at all. I didn't learn any medicine, but what I did learn is how to interact with patients on the telephone and in person, and sometimes dealing with complex situations, for example, if they've been waiting a long time or something like that, and you just learn to deal with people, which is really useful. And other things I did was I volunteered in a youth club and spent some time in a nursing home, where you're not doing any medicine, but you're learning to act in a responsible, caring role, which I think is useful.
Although a career in medicine can at times be stressful and high-pressured, the rewards and a professional satisfaction can be great.
I remember dealing with a really difficult case this year, where we had a lady in her 70s who'd come in with shortness of breath, and we found out that actually she'd had a lot of fluid surrounding the right lung, and of course we put a tube in the side of her chest, we put a chest drain in to get that fluid off. She felt better. So initially we thought we were winning this scenario, and we thought we were doing okay. Obviously we needed to find the cause of that fluid accumulation, and so subsequently we looked at different reasons why this could be happening. And one of the causes, unfortunately, is cancer. So we sent the fluid off to the lab, we did some scans of her chest and her abdomen, and unfortunately we did find the cancer in her pelvic area, and it looked like it spread. Despite knowing the fact that we may not actually be able to give her any treatment because it was quite advanced. So that was tough, and she eventually made the decision that she didn't want to be investigated any further, because she knew that we probably couldn't give her any treatment, and the test would probably make her more uncomfortable. So we had many discussions with herself and her family, and of course we respected her wishes fully. We got the palliative care team involved, and got her there looking after her in the community now for her symptom control, really. And it was difficult because we wanted to do more, but we knew that she didn't want it anymore. So we let her go home, and hopefully she's okay. She wasn't suffering anymore.
One gentleman, again on the renal unit, was on dialysis one day, he was having his blood taken out of him and filtered and put back into him because his kidneys weren't working correctly. He, unfortunately, his heart stopped whilst he was on the dialysis machine, but then we gave him CPR, which is chest compressions, and then he came back and he was resuscitated, and he did very well after that. And after a few more sort of ups and downs during his hospital stay, he went home and went back to doing all his normal activities. So that was a really good outcome for somebody who was technically dead at that point. But then we got him home, and he, as far as I know, he's doing really well. So, I mean, you talk about things with all the other doctors who are on the ward and the nurses, because everybody's affected by that sort of thing. And you work through it in your own mind, and you think, is there anything else you could have done? And then, once you're happy that you did everything that was appropriate, then you learn from it, and then you move on. And as you go through, you encounter lots of cases like that, and it's all part of learning to be a doctor.
Abortion is a typical case. Obviously, I don't believe in it, but according to the GMC and good medical practice, regardless of your views, you have to treat patient with dignity. So I'll give a brief outline of what is to be undertaken and refer them. And sometimes I've actually been able to sit to the patient and say, because of my beliefs, I'm not able to discuss this with you, but I'll refer you to one of my colleagues. So I've done that in a couple of cases. I was a paediatric SHO, and unfortunately the pregnancy had to be terminated because of fetal abnormality. And I think for whatever reason it was a bit late, so it was about 20 weeks, and 20 weeks old baby, and I had to take a biopsy from the baby. I took a muscle, and it was quite awful because this was a baby, about this big, and it was just awful. I don't think I was able to do much. I think it was actually the latter part of the day, so I wasn't very useful for the rest of my shift. Yeah.
I think perseverance is very important. There are times where it can, from the medical team's perspective, it can look like a losing battle at times. But working together as a team, I think teamwork is important, to know what each one's role is, such that we get things done quickly. Because obviously we're dealing with people's lives, and at times we need to work a little bit quicker than normal. I don't think anyone ever prepares you for how bad it can get. There are bad days, and I won't lie about it, but the support network amongst doctors is pretty good. So we do help each other through the bad times, and everyone's here, and everyone's usually quite friendly. But at the same time, there are loads of good times. It's a very rewarding job, and you don't realise how much of a difference you can make to people's lives when you're studying in school or in medical school. Communication skills is very important, especially with the patient as well. If they're a little bit anxious or they're very worried, and rightly so, we need to be there to reassure them that things hopefully are going the right way. And if they're not going the right way, then we need to be there to support them emotionally.
Depending on your focus, speciality courses can range in length of training, but often take several years before you are finally awarded the Certificate of Completion Training, CCT, as a fully fledged physician.
The people in my year are coming up to the time when we have to apply, so I'm only, how long now, 14 months since qualifying, so it's not actually that long before I need to decide on the vague direction that I want to go in. So I'm probably going to go and be a GP, I think, because when I first qualified, I wasn't quite sure whether I wanted to go into hospital medicine or into general practice. But once I've sort of experienced actually being in the hospital, then you realise what is for you and what isn't for you. And I do enjoy being in the hospital, but it's not something I think I want to do long term. As a general practitioner, you'll be working in the community, and you can see absolutely anything that comes into the surgery. So you might see babies that have been born a few days previously, right up to people at the end of their lives. So you need a very broad knowledge base to deal with anything that can come in. So that would be what the medicine would involve. And then surgery in a hospital is, again, normally emergency events where there's some physical problem, normally in the gut, but obviously can be anywhere. And that would involve an operation in most cases that will then need to be fixed. And then once the operation's been performed, then it's all about post-operative care, but hopefully the main problem has been fixed by that.
So as a general practitioner, you have to be aware of the array of problems. I mean, that's what your medical training gives you ability to do. In hospital, junior doctors, they're either doing medicine, so they know the patient they're going to see has a medical problem, and usually by the time we write them, we say, this is what I think it is. Often it is that, but sometimes it may be something different, so they've got a general idea what it is that they're dealing with because they're in that department. So we're sort of filter and gatekeepers as well. They say that you know the diagnosis, 60% of the diagnosis, by taking a history. So if somebody comes with a cough, you would say, when did it start? What makes it better? What makes it worse? Is it during the day? Is it at night? When is it worse? Is it worse at night? Is it worse during the day? Is there sputum? What colour is the sputum? Is it worse when you're lying down? Is it associated with swelling? You obviously want to know the smoking history, how many cigarettes for how long, You want to know whether there's a family history of asthma or any chest problems, or whether they were preterm or not. So that will give you a general idea, and depending on the answers to those questions, you have different things come into your mind. And again, then when you examine the person, you'll be able to say, this is what I thought. Does what I find go with this or the other? And then you're able to get a diagnosis put into that box. But you probably have one or two diagnoses, but often you just have one. Obviously, with different changes and different demands, one of the demands that we have now is having care closer to home and care where the patient is. So some of the things that in the past used to be done in hospital. So the move is for clinical care groups in different regions of the country trying to devise ways of trying to help people closer to home.
GP is very much about communication skills and communities and families, which is something that's a little bit more difficult if you're not natively from a country. It's a little bit easier to transfer hospital skills. But I have considered working in New Zealand, which is obviously English speaking, so it wouldn't be such an issue, which would be quite nice to do at some point. And it is, a lot of people do transfer between countries, and it's useful to get experience of medicine in a different country because they often do things very differently. Even somewhere like New Zealand, which demographically is very similar to the UK. I have spent some time working there when I was a student, and they do things a lot differently there.
I think being able to deal with your emotions is very important. Being able to talk about it to your colleagues, to your friends, to your families, and being open about it is very important. And also to have hobbies and to have things outside of work, just to anchor yourself, to realise there's something out there that you can do to enjoy, to take your mind off work, to focus off the work, because it can get quite stressful. But you know, if you work hard at it, if you knuckle down, you can get the results, and usually that tends to help. So from the top down, there'll be a consultant. There'll usually be one, maybe two registrars that work with the consultant, and then we'll have a team of SHOs. That may be a foundation year 2 doctor, maybe a core medical trainee, and then we'll have the health officers, the foundation year 1 doctors who've just graduated from medical school. I think just in the same way as you move from being a new junior doctor to being a medical registrar, the responsibilities become greater. You make a lot more decisions, certainly, and a lot more important and decisive decisions. The workload is different. It's heavy, but it's less so on the ground level. You deal with a lot of relatives, communication with the patient, you deal with complaints, you see a lot more patients in clinic, and you deal with a lot more things in the community. I'd say do plenty of research. I find it a very rewarding and very satisfying job, but it's certainly a job you need enthusiasm and passion for. And I think if it's not the right job for the particular person, then it may not be something they enjoy.
I think that the benefit I've gained is that I've had the privilege of working and being part of people's lives at a particularly vulnerable and distressing time for them. And you get a unique insight into how other people live, and you get to help them through whatever they've come into hospital with. So even if you're not physically doing anything for them, you're there as a reassuring, someone to provide reassurance and to help them through whatever they're going through. So it's a real honour and a privilege to be able to do that, and it's something you don't really get to do in any other career.
In 5-10 years' time, hopefully heading towards a consultant post and first year of medical registrar at the moment, so it's going to be a few more years to go. I think the more medicine I've done, the more I've realised how important research is. Doing the job day to day, helping people through their illnesses, it's great, it's a very rewarding job, but to make a difference, you know, in terms of a bigger scale, I think research is definitely an important aspect of it, and that'd be something I'd like to try my hand in as well.
The good thing about research is a question that we found in clinical practice that we can't answer, so people that are very clever suggest that maybe a medication, whether it's a new medication or old medication, can be used to answer this question. And so it's tested out in research. And so it's quite important to get answers to questions. The one I'm doing at the moment, it's people with Parkinson's disease. Again, we know Parkinson's disease, the proportion of them will go on to have memory problems, but we don't know what medication to use for these people. We know people with Alzheimer's disease, Aricept or donepezil is used to treat mild to moderate Alzheimer's disease, but we don't know about whether it works in patient Parkinson's disease. So the question is, does this work? So we have a randomised double-blind study. I think it's enjoyable, it's challenging, useful. When people have their problems sorted, they're usually grateful, and I think you see the satisfaction that people hopefully get better, and people can lead their life the way they want to lead it, as in the best health. So if you're involved with that, I think it's a privilege. I always tell my patients that they're the ones that are teaching us, because without them telling us what the problem is, we'll never know. And it's actually by talking to people that you learn, and so we're learning all the time. So I think it's interesting, very interesting.
I remember we saw a young patient in their 30s who'd come in very unwell. They'd actually come in with quite a bad pneumonia, on the background of being actually very fit and well, was very athletic. Like I said, during the winters it can, people get chest infections, but this person had really severe pneumonia, and we just weren't managing them on the wards. We'd given them lots of antibiotics, we'd given them lots of oxygen, but they needed higher level care. And actually at one point we thought this person wasn't going to survive this admission because it was that serious. Luckily we got them to intensive care, unit, and they supported their physiology. They basically maintained their oxygen levels. They'd had to intubate them to do so, and that gave us time for the antibiotics to work, and eventually after a week on the unit they got better, and eventually we got them home. But that was very rewarding to see someone that sick come out and actually get out back to normal very well.
Medicine's advancing all the time. I think that there's going to be a big technological boom, hopefully, if they can manage to link all the hospitals up to get notes and information between all the hospitals. That would make a very big difference to us, because if a patient comes here and they're not from the area, then we don't have any information about them here. So having all the tests and everything linked between the hospitals would make care much easier, and also from a community level, then all the information could be got to GPs much easier rather than people having to come to hospital to get test results and things. You definitely become more mature very quickly, just as a result of what you're doing, and you learn to become more assertive, because you're having to deal with other people in the hospital, and you try and get tests done and that sort of thing. You're always fighting for your patient and for the best thing for them. So I think that those are the things that I've really noticed about me myself.
You expect to do a lot of hard work, and it definitely is a lot of hard work, but at the same time it's definitely rewarding. The few times I have gone into the hospitals or GP visits, just speaking to the patients and seeing that trust when they just open up to you and tell you about their cases and how they're dealing with their problems, I think is really it's a privilege, really. So in that way it has been everything I've expected and more, really.
The decision to become a medical professional requires a lot of research and consideration. It's not only a career choice, but also a lifestyle choice, so only you can decide if it's the right fit. Suffice to say, the NHS is a booming sector, with an enormous breadth of opportunity for young, up-and-coming medical staff. Underlining all of this is the lure of a career that not only offers a diversity of hands-on experience, but also the opportunity to play an active role in helping people. What you choose to specialise in is up to you, a mixture of interests and skills that shape your driving passion and motivation within the medical sector. To learn more about joining the NHS, visit NHS Careers or TSU Professionals for more details. Visit tsuprofessionals.com.